Good morning, everyone. Welcome to today's presentation, Medications for Opioid Use Disorder. This webinar series is made possible by a grant award from SAMHSA, the Substance Abuse and Mental Health Services Administration. We are excited to provide this virtual series during the month of September, which is National Recovery Month. Today's session is being recorded and will be uploaded to the CMH YouTube channel for future reference. Please feel free to use the chat box to ask questions or add comments you have at any time during this webinar. And if time allows at the end, we'll do our best to answer as many questions as possible. Our presenter today is Dr. Mohammed Saeed. Dr. Saeed is the medical director here at St. Clair County Community Mental Health and is a board-certified psychiatrist and addiction medicine specialist. Dr. Saeed has practiced psychiatry and treated substance use disorders for the past 45 years. And with that, I will turn it over to Dr. Saeed.
Thank you, Sarah. Good morning, everyone. The subject today is that how do we take care of individuals who present to us for help and they have opioid use disorder? And we will define that in a few minutes. So a slight correction at the outset. A commonly used term is medication-assisted treatment, or MAT. And this term is really outdated. The new term for this approach is called Medications for Opioid Use Disorder, MOUD. And as we go along, we will explain why that is necessary. So the learning objective today is to define and understand the cycle of addiction, to understand the rationale for using medications to treat opioid use disorder, because in some ways it is sort of unusual to say that individual comes to us because they are abusing drugs and we are offering them other medications to take care of that condition. But we will explain why that is necessary. And we will also learn evidence-based treatment options for opioid use disorder and their outcomes. I don't have anything to disclose. In other words, I have not received any compensation from any drug companies. And this is a list of my references. These are some of the materials I have used to prepare my presentation today. As you can see, samhsa.gov is listed there, and that's a very easily accessible and very important source of information for anyone who wants to learn more about this condition. So let's start with the COVID-19 pandemic. Has that had any effect on the deaths from the overdose? And the answer is that more than 93,000 deaths have resulted from drug overdose in the US in 2020. This is 30% higher compared with previous year. So it seems like the changes in our lives that resulted from COVID-19 have had a significant impact and the higher rate of deaths from the overdoses. So the concept of the term called medication-assisted therapy, or MAT, is considered outdated. The word assisted means that the medication is just assisting the treatment process and the real treatment includes something else. So it implies that the medication is really not the actual treatment. Our new research shows that the medications alone can treat addictions for many individuals. And this is without any CBT, counseling, psychosocial approaches. And I have the reference right here. It was published in JAMA Psychiatry this year. Please feel free to look it up if you wish. So let's start with a hypothetical case. This is my hypothetical patient. His name is Sam. Sam was 16 years old when a friend gave him a narco at a party. Sam had never experienced such euphoria previously. He began to seek more narco. In order to achieve same level of euphoria, Sam had to take increasingly higher doses of narco. He started selling his belongings, stealing from his parents and friends to buy narco. When he could not afford to buy narco, he developed a strong craving and an unpleasant withdrawal symptoms if he was not taking narco and felt miserable. Then a friend introduced him to heroin, which was cheaper and easier to get on the street than narco. He started snorting, then smoking, and then finally switched to intravenous use of heroin. One of Sam's friends had died of heroin overdose. Sam had developed an infection where he was injecting heroin. He knew using heroin and injecting heroin was harmful to his health, but in spite of this, he could not stop himself from using it. So this vignette demonstrates certain points. The first one being that he had to take increasingly higher doses of narco. That means that an individual who starts using opiates is going to develop tolerance, which means that it takes higher and higher and higher doses to achieve the same goal. If one narco could give him a buzz the first time, few months later, it may take two, few months later down the road, it may take 3 or 4. So that's the phenomena of tolerance. When the person is not using those substances, he goes through a very negative emotional state, withdrawal symptoms, which are very unpleasant. And a time comes when his good judgment, his knowledge, his awareness that this thing is harmful, it can ruin my health, it can ruin my relationship. But the disease is such that it overtakes and it overrules person's good judgment, and basically the addiction then rules person's life, and the person really is kind of his own judgment and his own common sense and his willpower is paralyzed. So what is addiction? You can always look up books and read DSM-5 and read the full definition, but here is another way of remembering. If you can remember 4 C's, you can get a basic concept of what addiction is. So 4 C's of addiction are compulsive, cravings, consequences, and control. So compulsive act is use of substances or a behavior that is, it is an irresistible urge, especially one that is against one's conscious wishes. As Sam knows, Sam is aware that I shouldn't be using heroin, I shouldn't be shooting heroin, it can give me an abscess, my friend has died from it. He's conscious of that, but the urge to use overpowers that. Cravings, when the person is not using, the consequences don't matter. And the core of this whole concept is that the person basically loses control. In other words, the pursuit of that euphoria is so strong that the person doesn't care about the consequences, and the person keeps on using more and more and more substances, sometimes with lethal consequences. So let's take a look at what's going on inside the patient's brain when the person is dealing with addiction. So this is a schematic representation of what's going on in the brain. The basic idea here is that addiction is a brain disease. There are changes taking place in the brain, and we can pinpoint, we can specify which part of the brain is doing what. So this goes back to the idea, can you just say no to drugs? Well, it's just like saying, if you have diabetes, can you just say no to diabetes? We all know that that's not going to work, because diabetes is a condition in which the body is not producing enough insulin, or the insulin has become ineffective. So just saying no to diabetes doesn't work. You have to do certain things. This is not any different, because there are definite changes taking place in the person's brain. So that's one of the main messages, that this is a brain disease. So when Sam took his first dose of narco at a party, this would be considered binge or intoxication. This is his first exposure. And look at the blue color, and the blue color here is the area of the brain that was affected. And then Sam could not find narco down the road, and he went through withdrawal, and it says negative affect. So this is the extended amygdala and the part of the striatum, and this part of the brain is involved with withdrawal. And then after that, there is the state of preoccupation or anticipation. When the patient is not withdrawing, then he is just sort of thinking, he's preoccupied with the thought of how can I get more. So that's this part of the brain, orbital frontal cortex and prefrontal cortex. Those are the areas that are involved in that. So this is a more detailed description of this concept. The binge intoxication is sort of bluish color here. And the parts of the brain, the globus pallidus, dorsal striatum, thalamus, and ventral striatum are involved in binge intoxication. The withdrawal or negative affect is the extended amygdala, which consists of amygdala and the bed nucleus of stria terminalis and part of ventral striatum. And then the preoccupation state is the orbital frontal cortex and anterior cingulate gyrus, or the part of the frontal cortex. So these are the areas that we know are involved in different stages of this cycle. So this is to make a point that this is a brain disease. So let's now talk about opioids. Where do they come from? Well, this is the very pretty flower, poppy flower. And when the petals fall off, this is the pod that is left behind. And they make a cut along the pod. And then a resin or a gum-like substance comes out, oozes out of there. You scoop it out. And ladies and gentlemen, this person is holding a fresh crop of opium in this bowl, and this is the mother of them all. So opium has many derivatives. So we have listed here morphine, codeine, and thebaine. These are three main derivatives of the opium that you just saw in that bowl. Morphine first of all, opium itself has been used for centuries in medicine, and it has also been abused in many ways. It is one of the most powerful painkillers that we know. And one derivative, morphine, is used even today. For example, if the body is in a shock, such as a person who is in a traffic accident, has bled a lot, and the body is going into a shock, one of the first medicines that is used is morphine. We all know about codeine, which is used in cough syrups, and it's also available in acetaminophen with codeine as a painkiller. And thebaine is the other derivative of opium. And based on thebaine, there are many medicines that we use are based on this particular compound called thebaine, and we will talk more about that as we proceed. So what do opioids do in the brain? So in the body, I mean. So opioid, as I mentioned earlier, they produce analgesia. They are good painkillers. Some of the most potent painkillers belong to the opioid family. They also cause euphoria, the buzz, the feeling that people get when they use it. This is something very important to remember, that all opioid drugs, they cause respiratory depression. They go to the part of the brain which is responsible for making the body continue the respiration, and they slowly put it to sleep. And if the dose is high enough and that respiratory center goes completely to sleep, person quits breathing, and that's what leads to death. Opioids are also very constipating, and medicine has used this property of opioids to treat diarrhea, loose bowel movements for centuries. And even today, some of the medications being used for diarrhea contain opioids. They also suppress cough. So many of the cough syrups include derivatives of opium, such as codeine. They're also sedating. Now, vomiting is a symptom. Opioid itself can cause vomiting, and when people are withdrawing from opioids, they can also have vomiting. Now we come to, what do the opioids do to our endocrine system? Well, they inhibit the release of a whole bunch of hormones. Very important among them is the gonadotrophin releasing hormone. In plain English, sex hormones. So opioids go in your system, and they basically slow down or shut down the production of testosterone and estrogen, so that the person's sexual desire and sexual function is significantly impaired simply because of use of opioids. They also inhibit the release of corticotrophin releasing hormone, luteinizing hormone, follicular stimulating hormone, adrenocorticotropic hormone, and beta endorphin. So these hormones are related to, some of them are related to the ovulation in females and menstrual cycle. So those irregularities are very common. And I think many people know that beta endorphins are the hormones that the body produces after exercise, for example, jogging, and they are natural antidepressants. They lift our mood. So the opioids put a damper on that. So it is obvious that when a person using opioids feels down, there are some definite reasons at the biochemical level for that. And we already talked about tolerance. The opioids do produce tolerance, which means the person needs higher and higher doses to achieve the same result. This is another demonstration of the concept of respiratory center. And this is the brainstem, the pons, and the medulla oblongata. And you can see that there are a collection of nerve cells, which are called pontine respiratory group. This is dorsal respiratory group. This is ventral respiratory group. So these are the nuclei or collection of nerve cells, which tell our diaphragm right here, and the muscles in between our ribs, the intercostal muscle. There is an internal, there is an external. So it tells these nerve cells tell these muscles, keep on working, go on, do your job. So this thing is going on automatically, because all of us, we are not consciously telling our body, come on, go ahead and breathe. The body is functioning on its own. It's an autopilot. So imagine if something happens to this center, if this center slows down or goes to sleep, the diaphragm won't contract, the muscles between the ribs won't contract, the person quits breathing, and it can lead to a lethal outcome. So this is the mechanism. The purpose of this slide is to show that the opioids go to these respiratory centers, and they slow them down, and they, in higher doses, they put them to sleep. Person quits breathing, and that leads to death. So what happens when a person is withdrawing, or the person has been using Norco or Percocet or methadone or heroin, and all of a sudden they can't get it, they can't use it for a certain number of hours or days, they go through withdrawal. So for me, one easy way to remember is that when I worked in the hospital, uh, I would uh, uh, I would approach a patient who is new admission to the hospital, and I'm looking at the patient, and the patient is looking quite miserable. He doesn't want to talk to me. He's very irritable. And if he comes out of bed, he's holding a kidney tray or a bucket in his hand because he's vomiting. He is holding his head because it's hurting. His eyes are watering. His nose is running. And he's holding on to his stomach because his stomach is cramping. And he wants to go to the bathroom frequently because he is having diarrhea. So going through opiate withdrawal is miserable. It is not pleasant. So let's go through the list here. The person is very anxious and irritable. There are muscle and joint pains, headaches, dysphoria, meaning in plain English, the person is miserable. They are having cravings. I forgot to mention the yawning. One of the classical signs is that you see a patient in the hospital and the patient is opening his mouth so wide that you can see all of the oral anatomy. And then there are some other symptoms. Before the patient tells me what's going on, I'm kind of leaning towards thinking that we are dealing with opioid withdrawal situation here. So yawning is very common. Diarrhea, vomiting, anorexia, insomnia, people can't sleep, perspirations, goosebumps, runny nose, dilated pupils. So these are the acute symptoms. Now, it is also well known that if a person goes through that phase and then he abstains from using any opioids for, let's say, 6 months, some people can still have lingering after effects of opioid withdrawal called protracted abstinence. So even after 6 months, the person's blood pressure is low, their heart rate is low, and their temperature is down. And now this time the pupils are now constricted a bit, and there is decreased sensitivity of the respiratory center to carbon dioxide. So the use of opioids has long-reaching withdrawal effects that don't stop in days or weeks. They can go for even for after 6 months, they can be present. So what are the how do the opioids work in the brain? So the opioids can be classified into basically 3 main categories. Maybe there are more, but we'll stick with just 3. There is the full agonist, there is the partial agonist, and there is the antagonist. So let's talk about the full agonist. Think of it, there is a room, and if you enter that room, you are in a party situation, you are feeling great. Entering into this room brings euphoria, and you feel no pain. It's just fun. So the full agonist is standing at the door, and full agonist open the door wide open, complete open, and you go in and you get the full effect of that euphoria in that room. The partial agonist is a agent that opens the door only partially, so that you enter the room, you get a little bit of euphoria, a little bit of analgesia, but you don't get the full effect. What is an antagonist? Antagonist is like a bouncer. So if somebody is trying to get in to this room, the bouncer has big muscles and it'll kick that person right out. The bouncer can even go inside the room and drag people out, drag the person out and kick them out. In other words, bouncer does exactly opposite. The antagonist does exactly opposite of what the agonist does. So what are the examples of the agonists? These are your commonly used or misused opioids: morphine, codeine, your Norco, Vicodin, Dilaudid, OxyContin, Percocet, Opana, Methadone, fentanyl. We didn't talk about fentanyl yet, but we will in a bit. Heroin, Demerol, not frequently used these days. So this list of medication is a full agonist. You get the full effect of the receptor occupancy. Then there is a partial agonist. Top among them is the buprenorphine, which is the main medication used in Suboxone and Zubsolv. It's also sold as a painkiller medication called Subutex. Then there is Stadol and Talwin and Ultram. So the Ultram, again, is a partial agonist. That's the tramadol. Then go to the right column here, and these are the antagonists. Many people are familiar with the Narcan or Naloxone. This is a medicine that is used in cases of acute overdose of opioids. And then there is naltrexone, also known as Revia, and the injectable form is known as Vivitrol. This medication is FDA approved for treatment of opioid use disorder as well as alcohol use disorder. This is a slide showing the opioid receptor activation, and this axis shows the time in hours: 0 hours, 5 hours, and 10 hours. The red line here represents heroin. When a person used heroin, and look at how sharply and quickly the receptors are occupied. Heroin gets into your system so quickly, and the receptors are occupied so quickly that the person has a buzz or euphoria very quickly. What goes up must come down. So the quickly it goes up, the quickly it comes down, and within an hour, hour and a half, the receptor occupancy with heroin is basically down to 0. Now, the blue line here represents methadone. Methadone is also a full agonist, and it does go up slowly, not as quickly as it takes maybe an hour, hour and a half to reach its full occupancy, but it is a full agonist. In other words, it is occupying the mu receptors of opioids completely. It's a full agonist. On the other hand, the blue line here, I'm sorry, the green line here represents buprenorphine. That is the main medication in Suboxone and Sublocade and Zubsolv. And this line shows that when the person uses buprenorphine, the level goes up, and it takes about an hour and 15 minutes to get where it's supposed to be. And then it plateaus, and the receptors are only occupied or activated partially. So this is a partial agonist, and this has implications for treatment. And as we go along, we will explain that, because the full agonist has a higher risk of putting the respiratory center to sleep, and the partial agonist has less of a chance of affecting the respiratory center when properly used. We didn't talk about fentanyl before, but fentanyl is a very potent opioid, with the exception, the difference is that this did not come from mother opium. This was not derived from the plant, the bowl that I showed you earlier. This was synthesized in a lab and not derived from the opium. And this happens to be 50 to 100 times more potent than morphine. And in more than 50% of the overdose deaths that have occurred are a result of fentanyl, because it is cheaper and easily available for various reasons. So this is another way of explaining this concept. This is 2 milligrams of fentanyl, just 2 milligrams. This is enough to kill a person. 2 milligrams of fentanyl is enough to kill a person. And there is even a more lethal version of this called carfentanil. And I understand that's about 100 times more potent than this. Unfortunately, this is being sold on the street, and people many times don't even know that they are using fentanyl until we do a urine drug screen and we send it out to the lab and we find out that the person thought he was using cocaine, but it was either mixed with fentanyl or it was fentanyl itself. So many times people don't really want to kill themselves. People are simply trying to get a buzz. They want to get high or they want to go to sleep. So unintentionally, they end up using fentanyl, which they thought was something else, because fentanyl is being mixed with even cannabis, cocaine, and many other things. And innocent people are losing their life due to this deadly, serious drug. Another slide to explain the same concept of the full agonist, partial agonist, and antagonist. Full agonist, this is the methadone. Receptor occupation is 100%. And this is the partial agonist. This is buprenorphine, the main medication in Suboxone and Zubsolv. And the receptor occupancy is about 40%. And the down at the bottom is the blue line, blue dots, and that is the antagonist. That's the naloxone or Narcan. And that does not occupy, that is actually the bouncer. It kicks the other opioids out of the receptor, and it's just stands there at the door like a squatter and doesn't let anybody else come in. And if somebody is sitting there, it kicks them out. That's how it reverses. It's an antidote. It reverses the opioid effects. So how can we recognize an opioid overdose? Or what does a person look like? First of all, the person is going to be, we said sedation is one of the effects of opioids. So this person is, the level of consciousness is altered. The person is feeling drowsy, sleepy, and sometimes comatose. We also talked about the effect of opioids on respiratory center. So the respiration slows down and the pupils are pinpoint. If you have these three conditions, you're most probably dealing with opioid overdose. And the patient's skin is blue, pale, or cold. The body is limp, and there are choking or gurgling sounds. So looking at this, you see a person in that situation, of course you want to call 911 and ask someone to get some help, but immediately start paying attention to the person's respiratory airway. In other words, if the person is wearing a tie, make sure you loosen that and make sure that nothing is obstructing his trachea. His mouth does not have anything in it that is obstructing, and hopefully, and what you need to do is to use Narcan and to start some breathing treatments until the help comes. So once again, another slide to explain the same thing. Full agonists are methadone, partial. These are the medications used for opioid use disorder. Methadone being the full agonist. The partial agonist is the buprenorphine. When it's mixed with naloxone, it is sold as Suboxone and Zubsolv. These are strips that you put under the tongue or inside the oral cavity. And this buprenorphine is also available as a subcutaneous injection that is given once every 4 weeks, and the medication is slowly released to help the person with avoid any withdrawals. And the antagonists being naloxone, other name is Narcan, naltrexone, which is Revia, and Vivitrol. So methadone is a full opioid agonist. It has the full receptor occupancy 100%. It's only available through specialized treatment clinics for treatment of opioid use disorder. So if a person is interested in methadone treatment, they have got to go to a federally approved treatment center, a doctor in the community cannot write a prescription for opioid use disorder treatment for methadone. Even though methadone is used as a painkiller, it cannot be used to treat opioid use disorder in the community. It has to go through the approved clinics. So sometimes people have to travel long distances to get to these clinics, which is not very convenient. It can also take weeks to reach fully effective dose with methadone. But if you are using buprenorphine, which is Suboxone or Zubsolv, it only takes a few days to get to the proper level. Buprenorphine is the main medication in Suboxone and Zubsolv. Buprenorphine is a painkiller in its own right, and it is being sold as Subutex, which is a pill that people put under their tongue. It's also sold as a patch, painkiller patch called Butrans patch. It is a partial opioid agonist. It is long-acting, and it can be prescribed in the community. So physicians and prescribers have to go through some training and apply for a special DEA number from the federal government. And if approved, then any prescriber who is approved by the DEA can then start prescribing buprenorphine, which comes in the form of Suboxone or Zubsolv or Sublocade. So as opposed to methadone, where the individual will have to go to a federally approved treatment center, buprenorphine in the form of Suboxone and Zubsolv and Sublocade is available in the community, so the person can get help close to home, doesn't have to travel long distances, and in many cases, we are able to give the patient many days of medication at a time. And with methadone, some centers require, at least in the beginning, that the person show up there every day or 2-3 times a week to get the medication. So if you look at Suboxone, it is a combination of buprenorphine and Naloxone. So what is the rationale for mixing a partial agonist with an antagonist? And the answer is that Naloxone can cause withdrawal if it is injected. Adding it to buprenorphine prevents people from misusing the drug. So in other words, when this medication was being considered for opioid use treatment, there was a concern that people will just take this, they will dissolve it in a spoon or something, and they will inject it into their vein because it is an opioid. It is a partial agonist, but nevertheless, it is an opioid. So the idea came that if you combine it with Naloxone, which is an antagonist, so if a person was to dissolve this in a spoon with water and try to inject it, Naloxone will basically block the effect of buprenorphine. Therefore, the person won't have any effect. On the other hand, when this combination is used orally, if you put this Suboxone or Zubsolv film under the tongue, you are really not going to have any effects because Naloxone, when used orally, is really not bioavailable. What you're going to get is the buprenorphine. Naloxone doesn't really matter because it doesn't get absorbed, doesn't do much if it is swallowed or if it is absorbed under the tongue. This is what Suboxone looks like. It comes wrapped in a foil, and when you open it, you find this film and you put it under the tongue. So how do we start a person on Suboxone? Suboxone is, we talked about being partial agonist, but it also has some antagonist properties. So when we start a person who is diagnosed with opioid use disorder, we ask this person to abstain from using any opioids for 72 hours, which is easier said than done. We ask the person not to use any heroin, narco, Percocet, morphine, fentanyl for 3 days. And when they come to the clinic, they are miserable. They are in a state of withdrawal. They are puking. They are hurting. They are having stomach cramps. They are perspiring. They are very anxious and irritable. Our nurse will do a urine drug screen, check vital signs, and we will give this person a low dose of Suboxone every 30 minutes, sublingually under the tongue. And the nurses, every 30 minutes, we are going to check. We do certain rating scales. We ask the patient to fill out a rating scale. The nurse completes one rating scale. And what we are trying to see is, as we give the person a small dose of Suboxone, how many of those doses will it take for the person to say, my withdrawal symptoms are now gone? And patient provides feedback and tells us when the withdrawal symptoms have subsided. Patient is discharged home with a supply of a few days of Suboxone. Now, the question comes up, why don't we just, when the person comes to the clinic, why don't we just write a prescription for Suboxone and send him home? The problem with that is that if a person has some opioid substances in their system, and we give them Suboxone, what's going to happen is that Suboxone will kick out some of those opioids from the receptors, and the person is going to go through what's known as precipitated withdrawal. So we have had some patients who came to us for treatment, and we started them on Suboxone, and they went through withdrawal right in front of our eyes, and started throwing up, became very irritable, became very miserable, felt very dysphoric. So there is a reason for Suboxone induction. And even though those withdrawal symptoms are not very pleasant, it is actually in the best interest of the patient to start after a period of abstinence to avoid any precipitated withdrawal. As we mentioned earlier, so the buprenorphine is also available in an injectable form. It's called Sublocade. So there is a minimum period of 7 days after induction where the person is taking Suboxone sublingually. Then if the person is stable, he gets an injection of 300 milligrams of Sublocade, which is the same medicine as which is the buprenorphine. It is given under the skin in the abdominal wall, and 30 days later, 4 weeks later, he gets the second dose of 300 milligrams, and then after that, it becomes 100 milligrams monthly. So this is just a picture of a nurse giving the Sublocade injection subcutaneously. It is in the abdominal wall, and it leaves a little bump. And little bump is normal. It's supposed to be like that. And as the medicine gets slowly absorbed, the bump goes down. So buprenorphine can be dangerous when it's left open for the children. Most buprenorphine poisoning in children occurs due to improper storage of the medication. Small children mistake buprenorphine pills or films for candy. The source is usually a caregiver, a patient, or a visiting relative or a friend. A child may lick or swallow only part of a tablet, may become unresponsive, stop breathing, or even die. Symptoms of buprenorphine poisoning in children are drowsiness, vomiting, slow breathing, increased heart rate, agitation, coma, and death has also been reported. So take-home message is that in those households where there are children, these medicines need to be kept in a safe place where children cannot reach and cannot use them. Buprenorphine is approved for youth 16 years and older. opioid use disorder among youth is a chronic medical condition requiring long-term management strategy. This includes treatment with buprenorphine. Buprenorphine is relatively safe and well tolerated. When it's used in teenagers, it's effective and it reduces high-risk behaviors. Youth with opioid use disorder who use buprenorphine reduce their injection drug use, and the longer they use buprenorphine, the greater the reduction. This is a very important subject that comes up frequently in our clinical practice, and that is a person comes in and they say that they have to have Xanax or Klonopin or Valium or Ativan because of various conditions, and they also want to take Suboxone. And we, as a principle, don't use benzodiazepines with the opioids. And once again, Suboxone is an opioid. So why don't we do that? The overdose death rate among patients receiving both type of medications, benzodiazepines and opioids taken concurrently, was 10 times higher than among those only receiving opioids. When we combine Suboxone, Zubsolv with Valium, Ativan, Xanax, Klonopin, we are putting the patient at risk of dying. And unfortunately, we still see prescriptions being written like that, but it is just not safe. It goes against the basic principles of treating individuals with opioid use disorder. And this is a principle that we don't compromise. We do understand that some individuals are not happy with that, but at the same time, it is our duty as a physician, as a psychiatrist, not to harm the patient. This puts the patient at harm of dying from combining Xanax and Suboxone, Klonopin and Suboxone. And although I don't have a slide, but the same goes for other central nervous system depressing things, among them alcohol. If a person uses Suboxone and continues to drink large amounts of alcohol, once again, this combination is going to go to the respiratory center, put it to sleep, and the person can die. So we not only just encourage, but we make it very clear that if we are here to help the individual with opioid use disorder with medication treatment, but benzodiazepines and alcohol simply do not have any place. And we will offer the patient every possible help to help him avoid using benzos or alcohol when he's taking Suboxone. So we talked about treatment of opioid use disorder with agonists, which is the methadone, which is partial agonist being the buprenorphine. But what about the antagonists? Antagonists are actually also used for treating opioid use disorder. Narcan, as we all know, is the medicine used for acute overdoses. The medication that is commonly used in day-to-day practice for not only alcohol, not only opioid, but alcohol use disorder, and it's FDA approved, is naltrexone. The other name is Revia, R-E-V-I-A. And naltrexone also comes in a extended release injection called Vivitrol. So they are both indicated for alcohol use disorder and opioid use disorder. So these are non-opiate medications that can be used, and they are certainly an option for individuals seeking such treatment. So what about pregnancy? For a long time, we thought the best thing to do was to put a pregnant mother on methadone. But more and more, we are recognizing that buprenorphine, also known, one of those medications is known as Suboxone, is a safe and effective alternative to methadone for treating opioid dependence during pregnancy. Buprenorphine treatment during pregnancy has some advantages for infants compared with methadone and is usually quite safe. It's as good for mothers as methadone, and it's better for infants. The symptoms, when the baby is born, the symptoms of withdrawal, known as neonatal abstinence syndrome, include hypersensitivity, hyperirritability, tremors, vomiting, respiratory difficulties, poor sleep, and low-grade fever. The bottom line is that if the mother was taking buprenorphine during pregnancy, the neonatal abstinence syndrome is less intense and it is shorter, and the child, the newborn baby, doesn't have to stay in the hospital as long as a child who was born to a mother taking methadone. So it is actually a preferred treatment these days for pregnant mothers. What about breastfeeding? Because of the low levels of buprenorphine in breast milk, its poor oral bioavailability in infants, and the low drug concentrations found in the serum and urine of breastfed infants, its use is acceptable in nursing mothers. So we encourage our nursing mother, we encouraged our ladies who have given birth to children to breastfeed, and they can continue taking their buprenorphine orally. So let's talk about kratom. Kratom is a plant product that comes from Southeast Asia. Unfortunately, it's available in the community without any restrictions. The main component of kratom is metraginin. It is the primary alkaloid, and it's an agonist of the following receptors. It goes to the same opioid receptor where narco and methadone and buprenorphine go, and it is 10 times more potent than morphine. And it also goes to the opioid delta receptors. It's also an agonist at postsynaptic alpha adrenergic receptors, which makes it a bit of stimulant. And it's also an agonist at dopamine and serotonin receptors. So at low doses, kratom works as a stimulant. And as the person uses higher doses, it acts as an opioid. So I have treated individuals who were addicted to kratom, and we have treated them successfully with Suboxone. What are the symptoms of kratom intoxication? Tachycardia, agitation, drowsiness, nausea, hypertension, psychosis, seizures, coma, and death. So this is a very important study that is worth remembering. This was done in Sweden, and they were asking a simple question. If we put people on buprenorphine, which is Suboxone, versus people who don't take any Suboxone, but we give them therapy, who will stay in the treatment longer? Who will be abstaining from using opioids? So they took 40 individuals with opioid dependence disorder, and they randomly allocated to two groups. One group got buprenorphine, which is Suboxone, 16 milligrams sublingually for 1 year. The other group got only 6 days of buprenorphine, and they gradually decreased the dose and stopped it. After 6 days, buprenorphine was stopped, and they were given a pill which looked like buprenorphine, but it was placebo. And so 20 of those patients received buprenorphine for 12 months, and 20 of them received buprenorphine only for 6 days, and then they got placebo. And everybody participated in CBT group therapy, weekly individual sessions, supervised urine drug screen 3 times a week. And this is what happened. So this is the number remaining in treatment along this axis. This is the time from randomization, and this goes approximately 1 year. So this is the control group. This is the group that got placebo. So it started with 20, And by about 2 months, by about day 60, all of them had left the treatment and relapsed. All of them. On the other hand, the group, the 20 patients that received buprenorphine, 5 of them left the treatment or relapsed. 15 of them were still in treatment at the end of the year. What's the moral of the story? The patients on buprenorphine 16 milligrams a day or more were 1.8 times more likely to stay in treatment than placebo-treated patients. Buprenorphine decreased the number of opioid-positive drug tests by 14.2%. So here's a question. The question is, we have a lot of individuals who go for inpatient treatment for opioid use disorder. And a facility states that they provide evidence-based treatment to individuals with opioid use disorder. They admit the patient, they provide detox with buprenorphine for a few days, 3, 4, 5, 6 days, and then they stop all medications. No buprenorphine, no naltrexone, no vivitrol, nothing. But they get a lot of therapy, group sessions, 12-step program, individual sessions, a lot of counseling, and then 2 weeks or more after that, they are discharged back to the community with no medication, no buprenorphine, no naltrexone. And the question for the audience is this: based on the scientific information available to us today, as presented, some of that I presented here, is this practice evidence-based? Is it fair to treat individuals with opioid use disorder for a few days with buprenorphine and then stop all medications and then discharge them without any medications? Is this practice ethical given the current state of our knowledge? So ladies and gentlemen, I appreciate your time. I do want to emphasize that certain points that I have tried to cover. One, it is the concept of addiction is not a people who are weak or who have bad character. It is a brain disease. When a person is using substances, there are very demonstrable, clear changes that take place in that person's brain. Secondly, we know those areas where those changes are taking place. And when the person is withdrawing from these substances, they go through horrible, miserable situation, which is very unpleasant, and it drives the person to do many unpleasant things against their good judgment, and they get into trouble with the law, the relationships fall apart, they have financial issues, there are many legal complications. So the good news is that if this condition is approached as a medical condition, which is treatable with medications, the outcomes are wonderful. The overdose deaths go down significantly. People are known to become much more stable in employment. Relationships improve. So in many ways, this is a life-changing treatment, life-saving approach, and it is available in the community. Individuals with opioid use disorder don't have to go through many hoops, but it does require a commitment to treatment, and keeping up with the requirements of the treatment, like coming in for urine drug screens, meeting with the nurse. So this treatment is very effective, and we should rise above the stigma and not consider these conditions as a personal weakness, but deal with them as they are, which is truly a medical condition which needs to be treated medically with medications, and I must say with good outcomes. With that, I thank you for your time, and I think I will stop here. Thank you.
Thank you, Dr. Saeed. And to everyone who's asked, we will make this PowerPoint available. We can send it via email to the same address that you used to register for this session. So thanks again, Dr. Saeed, for your time and all your information. And thanks to all of you for attending our session today.